Hello, everyone. Thank you for joining us. Please begin to take your seats. We'll start any minute.
Afternoon, everyone. I just wanted to say welcome to the Ameriprise building and to this event that CHC is hosting. My name is Abu Arif. I'm the chair of the CHC Board of Directors. You'll meet a couple of other board members in this crowd, and I'll have John and Tinbit say a few words as well. Just a couple of things that I wanted to mention. One, really happy to have this conversation. I think more than ever, this is one of those moments in time when conversations become even more important. They become the foundation for action, and that's what we are about at CHC. We want to make an impact in helping communities and helping fellow Americans lead their healthiest lives. And that's a very simple way to say what our mission is. I joined CHC about 4.5, coming on 5 years ago. And I think I remember when I was interviewed for the board, my question was, why would you want somebody like me? Because I have no healthcare background. I'm a finance guy. And the board chair at that point, Kevin, was very kind to say, no, we welcome all viewpoints, and they all add value. And I think truly we have shown that it does. So that's what we're about. Most of you who are local here probably know Ameriprise or IDS. Back in the day, we've been woven into the fabric of the Twin Cities, state of Minnesota, for about 130 years. And really, when we think about, somebody asked me, is there a connection between Ameriprise and CHC? And I say we have a similar footprint. We operate in local communities as well as a company, even though we're a large multinational company. Our face to our clients is our financial advisors, and they operate in local communities. Their clients are their community members. They don't, somebody in the Twin Cities is not servicing somebody in Nebraska or in New York. There's going to be a financial advisor in that. So again, impact in communities, impact for people living in communities. And that's really the connection. When Gene and Morgan asked me to say these words, I was thinking, when they said, talk a little bit about Ameriprise and its history, and I was thinking about a couple of things that I had to research it firstly. But in 1972, we put up the IDS Tower, which has been an icon in Minneapolis. Apparently at that time, it was the tallest building in the city. And it stands today. And since then, we were acquired by American Express in '84, and our name changed to American Express Financial Advisors. And then in 2005, we separated, spun off as an independent entity, and we became known as Ameriprise Financial, and that's how we stand today. With that, I'm going to hand it over to John to say a few words, but welcome. Thank you for your participation.
Thank you. Well, thanks so much for hosting us. My name's John Stanek. I'm a Minnesotan, born and raised. I've been here my entire life. Proud of that. I'm on the program that was sent to some of you. It says I was chair of the Medica Foundation, but I'm the immediate past chair. We've had an upgrade, and my dear friend and colleague Gay Adams Massey is now the chair of the Medica Foundation. But I was asked to speak a little bit, and Tinbit's going to follow me, about why I chose to get involved in CHC as a Minnesotan. And the answer is pretty simple. I had a career, started out with Sue a minute or two ago. We were active in politics early in our careers. And then I went into public service and spent some time running a communications company. And when Quest was sold to CenturyLink, I was informed by my family that retirement was not an option because I couldn't hang around the house all day. So I said, well, what's my next chapter going to be? And I was very blessed and fortunate to have an opportunity to be the CEO of the Ronald McDonald House Charities of the Upper Midwest, a wonderful organization. And through that, I became acquainted with CHC, then Community Health Charities, for the workplace giving campaigns that they ran, a way to leverage employee and corporate support to further health interests. And at the time, we kind of described it as the United Way of the healthcare world. But how can you run As a matter of fact, when the team came and presented to me, I said, there's got to be a catch to this because you're going to do all the marketing, make us part of the corporate campaigns, and the dollars flow to us. What's the catch? And they goes, there is no catch. Well, that was great. I left the Ronald McDonald House Charities and went to do some other things. But I was approached by some of the Minnesotans who had been on the board, and they said, we'd wonder if you'd be interested in joining the board. And the reason I joined is the organization was in the midst of a pivot from not only focus on workplace giving, which has been a challenging and somewhat declining effort. It's not as much of the corner office dictated, this is where we're going to give our money. Employees want to be empowered. But there was an emphasis being placed on health equity. And because I was on the Medica board, because I had a personal commitment to learning more and trying to have an impact on health disparities that exist in our communities, in our nation, it was a perfect alignment because I appreciated what CHC had done historically in terms of workplace giving and keeping that going, but the health equity work was really important. And I'm sure we're going to hear from the speakers, and we're all aware, this is a really difficult and challenging environment. The work must continue. And we all know there's good words and bad words, and it's incredibly frustrating, I think, to be in this current environment because we all know the needs that must be addressed. And this is an organization that's trying to focus on that on a community by community basis. How can we bring people to common conversation to work on the unconscionable disparities that exist in our country when it relates to health, population health. And so with that, I'm going to introduce somebody who's way more informed on those issues than I am, and 10-Bit can tell you a little bit about herself. But thank you for being here, to the panelists and to the guests, and thank you for hosting.
Thank you, John. Good afternoon, everyone. Welcome. And thank you for being here. I'm 10-Bit Amaru. I am a physician. I am a critical care neurologist, have practiced in multiple different systems here in the Twin Cities, from Health Partners to Hennepin Health to, trained here in town, doing residency and fellowship, including medical school. I am currently the Chief Medical Officer at UCare, which is a local nonprofit health plan. And I came across CHC about 4 years ago. I've been on the board for 4 years. And at the time, I did not know what CHC did. But as a physician who has always been drawn to a mission-oriented health system and serving people that have faced healthcare barriers, when they said, well, we need someone who is passionate about health equity, I was ready. I didn't need to hear anything more about what CHC does. The commitment to be in communities, to work with community organizations, to serve individual communities is what is attractive to me. And I made a commitment that I would do anything to really partner with this organization, be on the board, or do whatever they asked me to do, because I believe in that mission, because I believe as a physician, everyone deserves to live their best healthy lives. We are fortunate enough to live in one of the best states when it comes to healthcare, but guess what? That is not true for everyone, especially for folks of color, for folks who are disabled, for folks who struggle with mental health and addiction issues. That's not the same for everyone. So if there is an organization that is committed to going into these communities to partner with nonprofits to address those healthcare issues, that is why I'm here. I think one of the questions that I was asked to talk about is statewide behavioral health was selected as a topic for this afternoon. Well, I'll tell you, I think we had a long conversation, John and Morgan and I, but what I remember is this is an issue whether you are wealthy or not, whether you are employed or not, whether you are a parent or not, whether you are a child or not. Mental health is a significant issue in our communities, in each community right now. The needs have been, there is not enough access. There aren't enough providers. There aren't good ways of addressing all of the needs that exist. And if we can't talk about that now, then when? So that is why we chose that topic. It's a topic that, if you're an employer, and your employees are impacted, you want to know what to do about it. If you're a student, if you're a teacher, I mean, this is an issue that impacts everybody. So that's why we picked mental health. And, me as a physician, I can't, I'm a critical care neurologist. I can't treat your medical needs if your mental health needs are not taken care of. So people don't come in two different parts, something above here and something below here, right? So we got to address the whole person, and part of addressing healthcare needs for the whole person is to really address the mental health needs. So with that, I'm going to introduce you, the CEO of CHC, and I know he can introduce himself in more details.
Thank you, Timbit.
Yep.
Good afternoon, everyone. We could do better than that. Good afternoon, everyone. Yeah. So first of all, I just want to start off by saying a couple of words, and I do this even with our team, is to really acknowledge the tremendous amount of work that's gone on to allow us to be in this space at this moment in time. So please join me in recognizing our amazing team. You heard about Morgan. Morgan, raise your hand if you have not had a chance to meet Morgan, our Chief Growth Officer. You have Becky in the back, who's actually our Senior Director overseeing our Workplace Solutions and Innovations team. We have Tyler, who is part of our amazing team. He's videographer in the whole 9 yards. And of course, we have Leanne and several others from our staff that's here, who's our Chief Financial Officer. In addition, we have amazing board members, and we could not do this without the amazing board members that you actually see here, and many of us are going to be joining us tomorrow. I do want to take a second to acknowledge what a partnership really looks like, and it's exactly this. We're a nationwide organization, but it's through partnership, and you'll hear this quite a bit throughout our conversation today, that we're actually able to make a meaningful difference. So I do want to acknowledge our host committee, my boss, well, they're all my boss, but the head of the boss of the bosses, our board chair, Riff, that you heard from, our amazing hosts, Timbit and John. We have Allison, who's actually joined us, and Michael in the back has also joined us as well. We'll have some other board members who are here. I do want to take a few minutes just to not just talk about CHC and then, of course, the partnership, but how deeply personal this is for me. I was mentioning to Amy that the point that Timbit just mentioned, how this issue cuts across every single dimension of our society. I mentioned to Amy that I had 2 fraternity brothers earlier this year that committed suicide. Would have never known. So when Timbit talks about the physical and the mental, not going to get emotional, the physical and the mental, you just don't know. You just don't necessarily know. So when we talk about creating healthier communities, and when we look at where we are in terms of the opportunities to really be able to, in partnership, think about how can we make a meaningful difference as individuals, as systems, as CBOs, as a journalist, as a provider, as a financial institution, as a community-based organization. It does require all of us to think about how do we ensure that we're creating the environment where individuals can truly thrive, thrive. So at CHC, we're an organization that's been around for nearly 70 years. And what attracted me to this organization is that, unlike other organizations, we have an opportunity through our partnerships with our nonprofit partners, through our partnership with many corporations, through our partnerships with state and local government and other entities, to really think about how do we address a lot of the barriers to health through a multi-sectorial approach. How do we come together and look at the broader ecosystem to ensure that no individual is being left behind, and that it's really at the intersections is when this is more likely to actually happen. And when you're in an environment where we're seeing some pushback, some drawbacks, some contractions, that means it's going to require all of us, whether it's Michael in New York, or John in Minnesota, or Allison in Dallas, Texas, or Timbit here in Minneapolis, or Arif, who is between here in New York, or wherever you are, to say, okay, how do we go wide but also go deep? How do we think differently about partnerships? And how do we ensure that this is just not a conversation, but we're translating this into meaningful action. And what are the ways we can actually do that? So at CHC, that is our belief. We're leaning into our mission. We're leaning into our name that you cannot make America healthier again without addressing the needs of the communities that are being disproportionately impacted. That there's a huge economic implication to this, aside from the social, and then there's huge national security risks as well. If our military is not well taken care of, if our communities are not well taken care of. So this is not about ideology, this is not about political affiliation, this is about what is in the best interest of our society, and how can we look at this through the lenses of the collective. So as John mentioned earlier, I could care less about terms. I'm more concerned about action and not getting distracted by that. So I am deeply excited about this conversation, both for the personal as well as for our strategic priorities as an organization, given the prevalence of this issue that cuts across all income categories, life stages, and ages. I'm a gerontologist by background, so sometimes that might come out. But I have the tremendous honor of introducing our panel. We will hear from them in a few minutes, but we have the amazing Angela Davis, who is the host of NPR News with Angela Davis, a weekday talk show that airs Monday through Thursday at 9 a.m. She joined NPR News in November of 2018 after more than 25 years of television reporting and anchoring in the Twin Cities and throughout the country. Has tremendous accolades. I am going to take a personal prerogative here and just acknowledge her roots to Maryland, having graduated from University of Maryland College Park. I know she has some family, and a daughter recently graduated from University of Maryland College Park. She has received tremendous accolades. And the other thing I would just mention, because she is a member of Delta Sigma Theta Sorority Incorporated as well, another Divine Nine. Yeah. So I just want to acknowledge her. I also want to take a few minutes to acknowledge Sue. I think you'll hear from her in a few minutes, but she has devoted her career to changing laws and attitudes that affect people with disabilities and their families. Since the fall of 2001, she has served as the executive director of NAMI, Minnesota, which is the National Alliance of Mental Illness, where she has grown the organization to the largest provider of family and public education and support in the state, and the state's strongest advocacy organization. She too has tremendous accolades and accomplishments, and rightly so, including being named one of 100 most influential healthcare leaders by Minnesota physicians, and also other accolades. And she just recently announced that she's going to be going into her next chapter of impact and evolution. So just want to congratulate her. I know that there's going to be some more coming your way. We have Kimberly, who's the chief executive of North Point Health and Wellness Center. And by the way, I think I walked by that this morning. I was I was walking all over the place this morning. I enjoy Minnesota, Minneapolis, which is a federally qualified health center serving over 30,000 residents in North Minneapolis. And is it Hennepin County? Established in 1968, North Point provides comprehensive medical, dental, behavioral health, pharmacy, laboratory, and human services. She has over 2 decades of commitment to community wellness through culturally responsive programs and whole person care. And I guess that gets back to the point that Timbit mentioned earlier. This is not like back during COVID where you could just be on a Zoom call in your suit and your pajamas and no one actually saw you. So just the whole person care. And then we have Jessica, who is a doctoral level licensed psychologist and enrolled member of the Turtle Mountain Band of, how you pronounce that, Jessica? Chippewa. She has dedicated her career to supporting the mental health and wellness of American Indian communities, which, by the way, when you think about differences in life expectancy, have the lowest life expectancy in the country. The lowest. So when we talk about addressing the disparities that exist, that we actually have to think about this very holistically in terms of exactly what are those ecosystems and those partnership opportunities to close many of those gaps. So I just want to acknowledge her in the tremendous work that she's done. So with that, I'm going to turn it over to Angela to take us away. And thank you all for being here.
Thank you so much. First, I want to say thank you to all of you. It's such an honor to sit in a room with corporate leaders and nonprofit leaders who prioritize mental health and really understand the significance of it. I'm here as a moderator today, but also I could probably be a panelist because I think I have a lot I could share about what I have learned about mental health and the need for mental health care, just as being a talk show host. So about 7 years ago, I joined NPR to do a live talk show where we take phone calls live from our listeners as I'm interviewing guests in the studio. And the frequency that people share their pain, their anxiety, their worries, their isolation, it's just every day. It doesn't matter the topic, whether it's whether I'm talking about the climate crisis or economic uncertainty. People are hurting and they're craving an opportunity to talk to someone, to listen to others, and to be able to honestly share what they're feeling. So I just want you all to know that mental health and wellness is more than a talk show topic for me. It's something really personal to me. In my 30 years as a journalist, the last 5 years have probably been the most challenging for me. For the first time in my 57 years of life, a couple of years ago, I got a therapist because I was really struggling. I continue to struggle. And I ask questions for a living, but I hate it when people ask me questions. And right now, the number one question I hate is, Angela, how are you doing? Because I don't quite know how to say it without, upsetting someone. And not that life is bad, but life is hard for everyone. So it doesn't matter, so much like what is going on or your socioeconomic status. Life feels really heavy. I feel really heavy. I share that with you because my first question from my three guests today is this. You all are in close contact with people who are expressing, their challenges. You're working with staff who are, in very close relationship with people who are struggling, and you're in leadership positions. So Sue, for more than 20 years, you're leading NAMI Minnesota, the National Alliance on Mental Illness here in Minnesota. How is Sue doing?
Not great, I'm going to be honest. I think that the stressors from, frankly, what is happening in Congress and on the federal level is really adding so much strain, and people are so worried about what's going to happen. The House passing the bill that will really cut Medicaid and will really impact people with mental illnesses, eliminating SAMHSA, just merging into another, organization. All the research that's being stopped at NIMH, the erasure of, DEI work, all of that is leading to people being incredibly stressed, which then, of course, comes through to our agency as well. And just sitting here going, how do we address this? How do we make sure these things don't happen?
And it affects the structure of families, right?
Yes, absolutely.
And I'm always very aware that the children are watching, the young people are watching.
Yes, and it really isn't okay to use some of those terms and words that are being used, and I think it just brings everyone, frankly, down to hear negativity all the time.
And so in the decades of working with NAMI, does this time feel different than maybe years ago? Absolutely.
I will say that usually I'm one of those people that, if I look at a glass, I don't see, it's half full, it's half, empty. There's water in it and I'm glad. But I'm losing a little bit of that hopefulness because I'm not sure how we can turn this around.
Kimberly, how are you doing over there at North Point Health and Wellness?
I appreciate the question. I think for me personally, I'm doing okay. I try to utilize, because we have behavioral health in our as one of our services we provide, I try to utilize the skills that they've taught us, because I know that people look to their leader for, support, information, being calm and consistent. And so I try my best to be in a space where I understand the things that are happening, and we still have a responsibility to our communities and to ourselves to figure out what is going to be next, what is the hope. I agree with you. I'm glad there's water in the glass, right? And let's just be with that today, and not try to think about, what all of the things, right? All of the contingency plans, all of the things. I just try to help people and myself just take one day at a time.
And so you have an awareness as a
Yes.
leader that your staff,
Are
they're
stressed.
watching you, folks who are interacting with the agents, they're watching you. But is that like an additional burden to maybe try
Well,
to appear different than how you're really feeling
yeah.
sometimes?
I think that I make a choice because I chose to be in a leadership role to take that on, and I know it's a responsibility that I have. But I also don't hide things. But I'm very open about what might be happening, being clear about how it impacts me, and I try not to be very emotional when I'm with my team. But sometimes I am, and I just try to own that this is where I am today. And I'll just give you an example. My medical director is also my provider. And so I was not feeling well, and I had to see him. And I was crying and everything in the room, right? Like, I need you to figure out what's going on. But I said, I know we have a one-on-one later, and so this is not going to be happening when we have a one-on-one. So just so you know.
So I'm still your boss.
And so, I got it together, right? I'm like, you're my doctor right now, so let's do this doctor-patient thing. But like in an hour is boss staff thing, so let's figure that out. So,
But to me, it feels good. Probably 5 years ago, I would not have been proud to say, I'm not okay. I'm very open. My colleagues will tell you, I'm happy to tell you what is not making me happy in the moment. It feels very liberating. So that, in some way, I think shows progress, right, Sue?
Oh, absolutely. It's okay to say you're not okay.
Jessica, how are you doing?
Actually, pretty anxious. But that's because of a lot of things. State of affairs, the fact that I'm in this building. I'm not used to being in outside my native community too terribly much. So whenever I have to step into that other world again, it gets a little unstable for me at times. But I have a great organization where we're able to talk about those sorts of things. So I do have support as a leader from my bosses, but we also have support from internally with our other colleagues. I really appreciate the relationships that we have because it does keep me stable, but it also allows me to have an avenue as a leader to feel safe, to know that I'm not going to be dragging my team down. We do a lot of laughing, so when I'm feeling like anxious, like how are we going to turn this ship around, like what you were talking about, how are we going to turn this ship around because we got to, I remind myself, you know what, we've been through this for 528 years, we're going to get through this again. This is nothing new, we can do this. And trying to remind ourselves all the time when we're getting down and losing that hope, kind of like, we can do this, we can do this on our own too, we have power within us. So I try to remind myself when I'm anxious like that about those things, but it gets hard. It's very hard.
I love what you said about feeling safe. My kids are young adults now, but I'm often saying to them, like, whatever you're going through, you're not going through alone. And it does feel better when you go even through the hardest of things with other people. Are you seeing more of that in your communities and people that you're working with?
I'm seeing a lot of desperation and pain. I see a lot of people coming into our building just breaking down at the front desk and trying to share their story with the front desk staff, and we have to just kind of envelop them, but it's happening more frequently, yes.
So I mentioned the children. Education is another one of the areas that I really care about, young kids. So many of us are worried about the children and the teenagers in our lives. Many of them we know are really struggling. There's a youth mental health crisis. And so individually and what you all are seeing in your jobs, what can adult caregivers, parents, the aunties, the uncles, the grandparents, the caring neighbors, what can we do right now to support young people who, really feel lost? Kimberly?
Yeah, I think it's going to be important to figure out ways in which to redirect some of the energy back to the things that we used to do when we didn't have phones, we didn't have internet, we didn't have all of the social media. I think there needs to be this kind of step back into some of the things that we used to do, like interacting with each other, playing games, being outside, taking advantage of a lot of things that are free in the community that a lot of folks don't like to do or don't even know about. I think that it also, for caregivers, really getting some information for yourselves and understanding the impacts that some of the social media and screen time and thing you have on kids, so you can make some different decisions about what you do for your own children. I know at North Point, we try our best to provide space for young people just so they can just be who they are. We have a number of clinics that are in schools, so providing services where the kids are in their normal course of a day is also helpful because it puts less stress on parents and caregivers to have to try to figure out where to get them. So I think just always thinking about what can I do differently, right? What's the outdoor activity? What's another activity I can do besides being on my phone? And really listening to what children are saying and taking it for face value, even though, it might not be anything. Always making sure that you're listening and getting kids the services or connections that they need as well.
But isn't it difficult? I mean, we tend to look at our own childhoods and what we thought was fun
Exactly.
for guidance and what we could do with maybe our grandkids or young people in our family. And it's so different. I don't even know how to give advice about anything anymore because I feel outdated. But folks who have the intent and want to help, they're stuck. Like, are there enough resources out there, do you think, that can help these caregivers of children and teenagers, be able to even find the words to have conversations?
I think so.
Think
All
so?
the work that Sue has done.
NAMI,
think
NAMI,
so.
I know you all do many amazing things. We've had many guests from NAMI on our show, including like peer support specialists, peer counseling. How do you describe what's happening with the youth mental health crisis, Sue?
I mean, so it is huge. There's no question about it. But I think parents and people who work with youth need to educate themselves, understand what the signs and symptoms are when you really need to worry, right, and really need to intervene, but also know how can you support your child's wellness as well. And I think the phone issue is huge. And so the multitasking that parents and kids do with phones is really not good for your brain, And so having those periods where it's like, there's no phones when you go to bed. There's no phones when we're eating dinner together. There's no phones when we're watching TV together. There's no phones, to really get rid of them because it's not good. You're not being a friend with someone, on TikTok. I'm sorry, you're not. And so we need to make sure that we're creating real relationships with people and not just through our social media.
But the adults, we are falling into those
yes, we are
patterns
too.
and routines ourselves.
We need to put our phones away just as much as we're asking our kids to do it. We have to model that for them, honestly. And I would really encourage any parent to take a suicide prevention class. QPR, Question, Persuade, and Refer, is a short class.
Tell everyone what QPR stands for.
Question, Persuade, and Refer, so that you actually know how to ask someone how they're doing, how to ask your child how they're doing, and they usually will answer pretty honestly, so that you know how to intervene.
And these classes, it's almost like taking a CPR class, right?
Correct.
And
Yes.
and where would one find a class like this, a QPR class?
So in Minnesota, there's actually now a statewide website so that you can look to see what classes are being offered, but NAMI also offers them free every month,
And
which makes it easy.
and the feedback, is it helpful?
Yes, no, it is absolutely helpful. You also mentioned peers, and so every NAMI across the country offers peer support groups, including for families of children and family members of adults, along with people who are living with a mental illness. And it is so helpful to, be in a room, even if it's a Zoom room, right, with people who are going through something similar. And the other thing that happens is you're seeing someone who has had a similar experience, but they're doing well and they're giving back to the community. And that also gives you hope that things can get better.
So speak more to that. So we have people who are experiencing a mental health crisis, and maybe they're in a hospital for a while, or maybe they're home being closely monitored. But the siblings and the parents, the whole family is affected.
Yes, yeah. And so parents in particular, we don't offer things for children because we're not a mental health provider, so we don't do that. But for parents, they can join the support groups and again, connect with other people and kind of understand what they're going through. You share resources, you share, tips and things like that. And you can share your worries without being judged. And that also is really important.
Very powerful.
Yes.
Right. Jessica, how do you speak of the youth mental health crisis?
Well, I don't know. In regards to that, it's an epidemic. It's definitely on par with what the pandemic was. And I think the biggest thing for them is to create safety, that they can actually have the conversation. We still sit in this society and we do not talk about this. See, you know, we would have no problem telling somebody, oh, I've got diabetes, I take medication for that. But if somebody were to say have a family member who committed suicide, but they felt uncomfortable talking about that, or their child shared with them, you know, I'm feeling like I don't want to be here anymore. Those sorts of things aren't talked about. We keep them quiet, and I think the issue is to normalize it for them, to allow them to know that it is okay to have that conversation, that I'm going to be able to hear that as a parent, that I'm going to be able to respond and not create anxiety for myself for them. One of the things that we do is we do a lot of pairing with teenagers with our elders. And so, for instance, when you were talking about like getting out away from the phone, an example is we bring all of our teens in with elders and people in different age groups like myself who are now 55 and are starting to not know what the heck teenagers are talking about. It really helps us to learn from them, but also they're learning the different traditions, they're learning the different things that we do. And so, for instance, we're growing tobacco right now to make a traditional tobacco, which is called kinnikinnick. So the elders are able to share their knowledge and teach them, and they have to be outside. They have to learn how to tend it. Then they have to learn how to make it. And then they go home and they share that information with their parents as well. So finding activities that engage the whole generation span has been very helpful for the teens that we're working with and the children that we're working with.
I would add one other thing, because you know sometimes it's hard with a teenager, like how do I have that conversation with them? You have it in the car. You can't look at each other.
I've heard this.
Yeah.
Tell me
You
about
can't-
this.
you
So
can't
what's
look-
going on in the car? The grown-ups driving.
Right, the teenager sitting next to you, you can't look at each other, right? And so sometimes it's easier to have hard conversations when you're not staring at someone. You could do it on a walk too, but cars, it's the best place to have those conversations.
It comes out. And I think about, you know, peer pressure. I think when my kids were still in high school, I was very aware that their friend group, you know, you're very affected by what your friends are going through. So if so many of the young people are struggling, then for, you know, an individual, you know, child or teenager, then they're carrying the weight of all of their friends, like all of their pain as well. Are you hearing and seeing that as well, Jessica?
Oh yes, many times we have teenagers coming in and talking about, I have this friend and they're really struggling. All these things are going on in their house. I don't know what to do, and they're having problems sleeping. They're having problems paying attention in school. They're having problems trying to find solutions. And so oftentimes they'll come and they will talk to somebody else that's not necessarily from the family, but somebody within the organization that they feel comfortable or safe with, and that means curating relationships. Being able to bring them in and know that they can come in and talk to somebody, but definitely noticing that weight is being carried by many people. A lot of our families are interrelated, and so we're a very small community. Everybody knows us, and so when one person suffers, it impacts several different families.
So one of the challenges when we look at mental health and access to care, there's a shortage, and you know there's just not enough providers. But then also when you look at different groups of people, different racial groups, there are definitely barriers that exist for Black folks and for Indigenous people and other people of color when they try to access mental health services. So let's talk about that. Like, what is different or more difficult for someone who is, you know, Black or Indigenous who is experiencing a mental health crisis and either does or doesn't want to get help than someone who is white? What have you seen, Kimberly?
Yeah, a lot of it is just tied to the stigma, right? I don't want to be labeled that I have some issue or a problem. So I'd rather just self-medicate, alcohol or other substances, or I'd rather just not deal with it at all. And I think the way the system is set up for folks to access it, it makes it difficult, right? Because a lot of folks that we see at North Point, especially Black and brown individuals, they just don't want to go through the process that it takes, right? I don't want to see somebody and then I have to tell that person my story, and then I got to tell somebody else, and then I'm being judged by what's being said. And we have to figure out a different way to talk about behavioral health, mental health. I had a meeting.
Even within Black families.
Yeah, they don't want to talk about it, but it's important to ensure that there's someone in that circle that can have the conversation and bring people along. Because if I talk to you at least 3 times about whatever's happening, my hope is that that 4th time you might say yes. And I have to be able to get you in to see the provider right then at that yes. Because if I don't, then it's a done deal, and it's going to take too long, right? Or I'm not coming back, or I don't want to talk about it. So we have to have spaces, the peer-to-peer space, just a community space where people can just come and have the conversation and not feel like I'm being diagnosed with something, but I am talking about my depression or my anxiety or the passing of my whatever. I mean, my husband had this encounter with a young person that lives across the street from us. He was arguing with the neighbor, and he went out and said, come on, all right, you need to just stop doing this, like talk to me, because the young man was African American, but the neighbor was white. So he talked to my husband and then talked to the guy, so he was able to de-escalate, right? So again, if I see somebody that looks like me, you're taking time to talk to me, I can at least try to change my brain to think about what can I do differently. And so how do we take the time to just have the conversation, not all the constructs? You have to have a DA, and then you got to see a licensed provider. And if you don't, then insurance won't pay for it. Just talk to somebody and then help us get to those other stages so that people can feel like I have some agency over what's happening, and I feel comfortable talking to someone like Jessica who has a license and all these other things and is going to get paid for, and I don't feel stressed about maybe not being able to pay the bill.
But have you found that a lot of Black people, like they particularly would prefer, if they do make a decision like I'm going to see a mental health professional, they would like a Black therapist.
Yes,
and so what's the challenge with that?
I mean, we have about 60% of our staff are people of color, and 55% of the folks that come to get services are people of color. So we try our best to do that, but in the instances where we can't, we just try to provide a safe environment where people feel comfortable. And sometimes they just have to bring someone along. So a lot of times our human services staff will go to the behavioral health department with the individual, sit with them while they're talking to the therapist, and make sure that they're comfortable, and then follow up. Okay, so you saw Dr. So-and-so, how did that go? Is that working for you? So they always have somebody along with them on the journey to make it easier for folks to say yes, right? Because no is simple, like I don't want to do it, but the yes, making it easier to say yes and consistently say yes is what we're trying to do.
And Jessica, we've talked about on my show a lot, culturally relevant healthcare, and is it important if you are Indigenous that you have someone who's also Indigenous to talk to about mental health issues, or is it more acceptable now or okay to maybe have a white therapist, or is that still a barrier to getting the care that you might need?
It's still a barrier. It is always a preference that they're talking to somebody who's Indigenous, because Indian people have a very unique relationship with the federal government that other groups do not have, and it's complicated. And that complication means that they have to spend time trying to explain their history to another provider, even if the provider doesn't ask it, because sometimes providers will make recommendations that will actually be harmful, that they don't realize are harmful, but the book has told them that somehow that's going to be the right thing to do. But in the Indian community, it's going to be frowned upon, and it's going to get them in trouble. So having to explain those sorts of things to a person who doesn't know that is exhausting.
Yeah.
But I do find that the people that we have to have allies. We hardly have any mental health professionals in our community, so we have to have people that are well trained and are compassionate. And what I found is that those providers who are authentically themselves do best when they're working with their people. Just being authentic and being able to make that human connection, and being able to sit there and maybe listen to something that the pain that is going to come that they may not understand. It's vitally important that they are able to listen to that and hold that, because oftentimes we also are afraid that their story is going to be so bad that we're going to break that mental health provider because it's a horrible story, right? And so it's much easier to share that with somebody from your culture, because they get that. And what I found is when I have people who won't do it, like when you need help, you want it then and there, you're going to lose them a lot of times, just like what you were saying, Kimberly, is there are people within the organization that are often very trusted, but they're not necessarily a mental health provider. So I'll be really sneaky and I'll go, hey, we want to go and have some coffee with so-and-so. And you go, I love her. Yeah, let's go have some coffee. And they go and sit down. And I guarantee you by about the third visit that she's talked them into coming into therapy.
Oh.
So you really need those trusted people. You don't need to have a mental health provider. You need to have a person that is trusted and they have confidence in, that they know that they can talk with them and it's going to be okay.
And Sue, what have you seen in the 20 years? Have things gotten better? Have we seen some improvement with both the number of therapists who are people of color and the number of people of color and Indigenous folks who are willing to go to therapy? Has it gotten better?
I think it has gotten a little better, and there's been some things we've done legislatively to help with that. So there's grants called the CMIG grants, Cultural Ethnic Minority Infrastructure Grants, to really help providers of color provide supervision for free, do things a little differently in terms of not the whole diagnostic assessment in the beginning and things like that. We actually passed legislation a couple of years ago to pay for BIPOC mental health professionals to become supervisors, so that people who have finished their master's degree can find someone to supervise them from their own culture. We also required all mental health professionals to get continuing education on becoming more culturally informed and responsive. And then actually the boards of all of the mental health professionals also being diverse as well. So there's been a couple of different things that I think have helped, because we had a lot of people who finished the graduate school and didn't go on to become licensed because they couldn't find supervision, because they couldn't pay for their loans. And the other thing is, frankly, the national tests are not culturally informed at all. And so the social workers actually got rid of, you can have an alternative to the test because they found that it was actually a lot of people of color and men who weren't passing it. So they wrote the test for white women.
So I'm wondering, are most therapists aware that you can't treat everybody the same? That maybe they need additional training, or that they're missing some things, or there's some things that they didn't get when they were going, through their college years or through their classes that would be helpful for them in trying to work with clients?
I teach public policy to the Graduate School of Social Workers, and I have to say I'm so amazed at how aware they are, even different than 5 years ago.
Mm-hmm. Yeah, I would agree. I think the younger ones are more aware. Some of our older ones are still a little more like, I'm doing what is that book called, DS9 or whatever it is? Yeah, and I'm just using that. I'm like, so we make sure we provide training on a regular basis that's mandatory, that really talks about the cultural differences. And we, as we talked about earlier, this kind of whole person integrated care model that we have in North Point, they have to work collaboratively together across all disciplines. So they get to learn and be exposed to other things and other programs, other people, other experiences that helps to build their acumen around how do you provide culturally responsive care.
Let's talk about the pandemic and the lessons that we learned from the pandemic. And so what do you think the pandemic taught us about the need for mental health services, particularly in underserved communities and communities of color, Sue?
I think there's a couple things. One is loneliness and how that really so negatively impacts people's mental health, and lack of human touch, lack of face-to-face interactions. It just wasn't healthy. We had to do it, but it just wasn't healthy for anyone. And I think the other thing, of course, we saw is that the BIPOC community, people died at a higher rate than the white community, and so you had families experiencing more death than others, and that, of course, certainly takes a toll. And especially during COVID, when you couldn't have the closure, you couldn't have the funerals, you couldn't have the get-togethers, and that was that happened to me, and it was a very, very difficult thing. So I think those are some of the things.
What about telehealth?
Yeah, telehealth can be great, but then we also have to remember that you need to have a smartphone or a computer. And so one of the things we've been fighting for in the legislature is to make sure that we can still do telephonic care.
What is that?
Just a normal little phone. Because for some people, really, if you don't have a lot of money, if you're homeless, all of those kinds of things, you're not going to be able to do normal telehealth. You need to do it that way by just a normal old phone. I don't think it's the best, but you're staying connected, which is really important.
Loneliness, I'm trying to remember the Surgeon General declared loneliness is
an epidemic.
has there been an improvement, or is there any way to engage it, or to gauge whether there's been an improvement now that we are back, in person doing events, traveling again, or are people still lonely?
I think they're still lonely. I think people are still. Because you see people fighting to even have to come back into the office, right? They don't want to. They don't want to come back. They still want to stay at home. But the way that they engage with each other when they are in person is still a little strange. I think people are still trying to figure out and reconcile this. I'm in person with. I had so many months of not having to talk to anybody.
It still doesn't feel safe.
It's still exactly. It's like are we safe? Is everything okay? And, in the healthcare environment, we still have a lot of our staff, they still wear masks, especially, we have protocols, but, a lot of people feel more comfortable just wearing the mask. And so I think having to relearn how to engage with people is difficult. And having to, not always pick up the device to be on the Zoom call is always the first. That's the default now. Not meeting in person, that's the default. And I think when we have to switch back to that not being the default for people, and maybe they can engage differently. But folks lost family members who they, would always hang out with and engage with, and now they're not here, now what, right? Mm-hmm. And I think people are still just trying to find their way back.
Jessica, what do you think we learned from the pandemic about mental health services, particularly among Indigenous communities?
Well, I would say that the mental health field has not grown to what its potential should be. It's broken. It's been broken for a long time. All of us in the field know this, and the pandemic just accentuated that. So, for instance, those families who already had maybe really struggles within the family unit, now they can't leave, which means now with telehealth, if I have somebody who's in a domestically violent relationship, it's unsafe for me to do that with them when that person is in the home. Or if there's not a safe place to go to even have the session. What we found is we lost almost the majority, I would say more than 3/4 of our teenagers during the pandemic. They would not participate through telehealth. They were struggling with loss of family members that were dying. The reservations had the highest loss of family members. Our people in the state of Minnesota had the highest losses in the reservation, and they couldn't get there. They couldn't be a part of that. They couldn't honor their relative and let them move on. So there's all that grief and loss mixed in, which caused problems within the family unit, so there's nowhere to go with that. So what we learned was, we learned that it was just accentuated the things that were already in the community and made them more challenging. But the positives that did come out of it that still work today are that it has reduced for those people. We found that people that we could not successfully get to come into the office, they were now coming and showing up. And so there were, even though we lost teenagers, we had people that were engaging because they didn't have to worry about childcare. They didn't have to worry about transportation. We were able to get them the technology that they needed, and they had the ability to do that. So we did find that, and that has been very helpful for us, even with the fact that we're back in the office. We still find that our younger people definitely want to have in person and that they do better that way. But we found that there is some helpfulness with some of it to reduce some of the barriers.
It's important to note too, though, the prevalence rate increased after COVID.
The prevalence
of depression, anxiety in particular, increased dramatically, and especially among our young people. And some of that, of course, is due just to what was going on during COVID and deaths and things like that. But also, they found that people who had COVID also became more depressed. And so they're not sure if it's due to the inflammation of the brain or something like that, but we also saw that as well. So we had a very fragile mental health system, and then we increased the needs and weren't able to respond.
So it almost seems like the mental health system is already fragile. Was it ever even effectively built? Did it ever exist in a way that made sense?
Well, my saying is our mental health system isn't broken, it was never built. The institutions were not a mental health system. And I think what we've done over 40 decades is we've identified what works, so we actually know what works, we just don't pay for it.
Because I was going to ask, well, okay, we have all this knowledge, so now this is an opportunity, right? The time is right now.
Yes.
Right. Let's talk about the role of substance use in mental health, and what can healthcare organizations do to help people make decisions on their recovery journeys. If I look back to many of the shows that I have, talk shows I've hosted on addiction and the people who've called in, so many stories of people relapsing, right, enduring setbacks. And so what can be done, or what is working when we look at substance use disorders? What's working? Jessica, what have you seen work that we could?
Well, what I had noticed is with a lot of times insurance companies want people to go into inpatient or residential or intensive outpatient, and they only have a set amount of days to do this in. And these are patterns possibly that have been in place for generations, not just with this individual, but within a family unit. And you can't solve something in 28 days or based off of insurance restrictions. You need to be able to keep people and hold them and keep them safe and give them stability for a much longer period of time. So we found that we've allowed people to stay in our chemical dependency programming much longer than the norm. The other part that we found that has been successful is that everything we go back to, everything that we have for healing and resiliency within our community is always within our traditions, our values, and our ceremonies and our practices. Every time we go back to that, and every time we bring that into the world, into their world, it creates this positive cultural identity, because that has been ripped apart. The idea of a Native person, their cultural identity, is not in a very positive viewpoint according to the United States and how they look at us. And so when we bring that back in and we show them the beauty in it and what we've lost and how they can regain that and get that back, like these are the ceremonies that we bring into the room, they respond unbelievably well. It's almost intuitive for them. So for instance, when we're starting our group, we start off with prayer in the morning, and they're learning their songs, and they're talking about their history and how it's impacted them, but they're also talking about the beauty that they see in it. So every time we return back to our culture, that has the healing aspects already in it. We already know that. We already have that. We just got to take off the trauma and see where it's at. We've already been gifted that by our relatives that came before us who've suffered for that. So once we embrace that, we have seen people do really, really well as long as they're given the time to do it.
What are you seeing, Kimberly, at North Point when it comes to people dealing with addiction? What's working? What is getting in the way? And how whole families are affected if you have a family member that's dealing with it?
Yeah, at North Point, I think we take this kind of continuum approach, right? So we start with, we have some harm reduction approaches where we have access to clean syringes, because we know people use, but we want them to use, in a way that is safe for them and those around them. And we always offer, additional supports and services should they want them, but we're always available when people need us, right? So, and when anyone decides that, okay, I'm done using, we move them to the next stage, because we have medically assisted therapy at North Point as well, where we
What does that mean?
We provide medications that help to wean people off of the substance that they use, alcohol or opioids. We do both, but that comes with not just the medically assisted therapy. You also get connected to behavioral health, where you see a therapist, and you get connected to resources in the community. And we know it's a cycle, right? We know people who have addiction, it's a chronic condition, in my opinion. That's how we like to talk about it. Just like with your diabetes or your hypertension, you gotta take your medicine every day. You gotta walk, you gotta check your A1C. Same thing, people relapse, we know that. And so we have an environment that is welcoming, regardless of what stage you might be in. And then if you get to recovery and you maintain your recovery, how do we get you to come back and support others going through the program? So that's how we do it at North Point. We're trying to get our system together across both internally and externally in the communities that we serve to be able to move people along this continuum.
So what do you want people to know about the role that substance use is playing in mental health, and what can organizations do to help people as they try to make decisions on their recovery journeys?
I think the hard thing is it's about 50% of people with a substance use disorder also have a mental illness, but our system doesn't treat them that way. So our system is kind of like, well, no, first you have to go through a substance use disorder program, and then we'll take care of your mental health. Or we're going to take care of your mental health first and then send it there. And you can't do that. It's, your head is connected to the rest of your body. And so we need to have many more programs that are actually doing an integrated approach so that you're working with it at the same time. And for some people with a mental illness, it isn't so much that they're addicted, it's more that it's self-medicating, right? I'm gonna, if I take this drink, I'm not gonna feel as anxious going into the room or things like that. And so I just think we've done a pretty crummy job of treating both disorders at the same time. And that's why we see failure, honestly. And I do think peer specialists, whether it's a peer who has a mental illness or a peer with a substance use disorder, is really helpful, again, because you're learning from someone who has walked that path, and they're better, right? They're in recovery, and that gives people hope too.
What can be done in workplace situations? Employers, we're speaking to employers now. We know employees are struggling with their own mental health, and the whole person comes into work and is interacting with colleagues. Everybody's bringing something with them to work, but employers, there are limits and boundaries. But what have you found is helpful in how employers approach that? Asking for a friend. I really do feel bad for managers because I say people are peopling right now, right? They're taking care of maybe elderly sick parents. They've got children who may be in situations that they need help. They've got their own physical, medical needs. It's just a lot. If you're the boss, what are you supposed to do? Because the work still needs to get done.
But it's not going to be done if you don't address their mental health. That's kind of the bottom line. We actually provide classes to lots of employers around
NAMI provides classes.
NAMI provides classes. And we've actually seen, and I think it's because of COVID, a real interest by employers who are worried about their employees' mental health. And so some of it is just making sure that everyone's educated so that, again, early identification and treatment yields the best outcome. So making sure that you know about it. Even just placing, a poster about depression in, the workroom or whatever makes it sound like, well, maybe I can talk about it. But the other thing I will say is that there's two things that employers never, frankly, look at. So one is very few know what an accommodation is for mental illness. Have no idea. So someone has bipolar disorder, how do I do an accommodation for that? And so there are resources out there.
What is an example of an accommodation for someone with bipolar disorder?
It might be that they have a later start time because the medications make it hard to wake up. It might be someone with an ADHD doesn't have a cubicle near the elevator because they're hearing it all day long and then they get really distracted, or they get noise canceling headphones on them. Making sure that they have time to actually go to their appointments, that you're not like, well, you can't use up all your sick time, but providing that flexibility because you want them to get to their appointments for sure. And then the second thing is that very few employers, frankly, look at what is your mental health coverage. And so, it's like, are you covering intensive residential treatment? Many are not. Are you covering in-home services for families of children so that they can get that support? Probably not. But they just, and you don't know, right? All of a sudden you go to use the service and then you find out that your insurance plan doesn't cover what you need. And so we've also been pushing employers to look at what is it. And to be honest, the only way that mental health parity will become a reality is when employers demand it in their health plans.
So if I'm an employee, is it to my benefit to inform my employer that I have a diagnosis of a mental health condition, or am I putting myself at risk by doing that? I like the idea of accommodations, but is it always a wise thing to do to disclose that?
If it's impacting your ability to do your job, yes, and you have a right to that. And that's why, frankly, we've been moving away from using the word stigma, but talking about discrimination. Because what people are worried about is they're going to be discriminated against from, getting a promotion or getting a raise or actually getting fired because they live with schizophrenia or something like that. And so I think we have to start using that word as well. But people have a right to accommodation, even with a mental illness. And if you need that accommodation to do well in your job, you should demand it.
Jessica, what have you seen, or what do you think employers could do to support people who are working on their mental health and are actively trying to be well so they can be productive?
Yes. Well, we have families in our title, American Indian Family Center, and if we look at each other as family, we need to be looking at the way in which we treat our employees differently. And if your head of your organization does not believe in the wellness or the mental health of their staff, it is going to be very challenging to get that need met. So when you have somebody from the top down who says, no, we're going to be doing wellness 3 times a week, and you can do that on your work time. When you have your therapy appointments, guess what? You can go and do that, and we'll find a way to get the job done. But if you don't talk to me, then I have no way to know that. So encouraging people to talk more about it and that it's okay. In our building, everybody's walking around with trauma. So if we don't help them with that when they're having a struggle, then they're not going to be able to do the work anyway. And they're going to be struggling themselves. So we have a really nice system of being able to know that if somebody's having a really rough day, there's somebody else within the organization, for instance, that can just go and be with them. You have to have communal spaces where people can connect and just be with each other as human beings. So I think employers really need to recognize that they need to offer those opportunities for wellness.
So I should be able to say, hey, Deb, I'm going to the dentist. I'll be back in 90 minutes. Mm-hmm. I should be able to say, hey, Deb, I'm going to see my therapist. I'll be back in 90 minutes in the same way.
Yes.
Right?
Yes.
Yes.
Yeah.
Kimberly?
I mean, I agree with what they've said. It's really important as a employer to ensure that your employees understand the benefits that they do have and that they use them. Because we have, employee assistance programs. We have pretty good, decent healthcare coverage that covers things like mental health and, appointments and things like that. So, and we're always flexible with people, right? Because we can see their behaviors. You're coming in late, or you're not getting your work done. And so having those conversations with staff and hoping that you have a good relationship so they don't have to disclose everything. But if they do have a mental health issue, or they have something else going on, that they're using the types of leave that we have available to the best of their abilities, that they're using employee assistance program. I mean, I say it all the time. Somebody tells me someone lost a family member, make sure they have EAP, make sure they know we're here to support them, or whatever's going on. So I think as an employer, if your staff aren't well, your business isn't going to be well. So it makes business sense to me to put the dollars into the things that make sure that your staff show up well and want to come back. So,
Kimberly, Sue, Jessica, thank you for your time.
Thank you.
Yes, so we have time for some questions. We have about 15 minutes for questions. If anybody would like to ask a question, please let me bring the mic to you so you get recorded for the show.
Let's do some questions and answers. We'll take a few questions.
Thank you very much. I'm Amy Carlson, Hennepin Healthcare Foundation. Can you share an example of what country or what state or what nation is doing it right or doing it better than the current state we've talked about today in Minnesota and the nation?
Who's getting mental health care right? Sue?
Oh, hardly anyone. No, I'm serious. If you look at other countries, people are like, well, United Kingdom. Do you know how long kids are waiting to get into any kind of therapy there? Some of the Scandinavian countries do it a little bit better, but honestly, no one does it well. And even if we look across the country, there might be, maybe Massachusetts is doing this well, but there isn't, frankly, another state I would move to, because every state, no state has fully built their mental health system, to be honest. So I think we can learn from some of the pilots and things like that that other states have done, but I'd still live here.
Anybody else have a question?
You talked, Sue, about we don't have a system that's built. Would you give us a vision for what it would look like?
Great question. Mm-hmm. What would the ideal system look like?
Ooh.
Well, I think being able to access help right away, not having to do a full-blown diagnostic assessment in the beginning, but bereally just being able to talk to someone and kind of work on those kinds of issues. having enough residential treatment for when kids or adults need it. We certainly need more hospital beds. It's not, it's the most costly part of our system, but when you have that many people boarding in an emergency room, you know that we don't have enough beds. And then I think it's really looking at the social determinants of health, right? So, I remembered a long time ago, it was actually Medica that funded housing supports along with their Medicaid patients, because it's like if you're unhoused or in unstable housing, you're not going to be able to focus on your mental illness or your substance use disorder. And so we need to look at those kinds of issues as well. Really it's just being able to get the right level of care at the right time in the right place is really kind of what it boils down to.
That you mentioned emergency rooms. Remind us what is happening in emergency departments, particularly with children and teenagers right now, because I've read some stories about this.
So children are boarding in the emergency room, and it's children who have more complex needs, and there's nowhere for them to go. Residential facilities don't necessarily have the staffing or the funding to be able to meet their needs. The inpatient units are saying these are kids that we can't really address, and there's not an open bed. And what's unfortunate, although we have a bill this session that hopefully when we see the real bill, in the next couple of days will be in there, is that those families are actually being referred to child protection. And they're being charged with neglect. And they are not neglecting their children. The system is neglecting them. And I think it is a horrible, horrible practice. And referring a family to child protection doesn't mean that child protection worker has a magic wand and can get those services. We have just ruined that family's, a whole family system. So we need to be developing more intensive treatment and supports for these kids. They usually don't just have like simple depression or just had maybe a suicide attempt. It's kids who have more kind of aggressive symptoms. They usually have a combination. They might have autism along with bipolar disorder and anxiety. So they just have more complex needs, and we don't have any place for them to go.
Hi, Rick Elariaga with Medica. I'd be interested in hearing about your viewpoint on early detection and prevention type programs, as well as potential ER diversions that you think would be beneficial in all three of your,
So I'll start with, in Minnesota, we have mobile mental health crisis teams covering all 87 counties, which are very helpful. And now with 988, it's very easy to connect with them. But they're not funded in the same way as police. So for example, the total funding in the state for all our mobile crisis teams is still less than the City of St. Paul's Police Department. So they're not going to be able to respond in the same way. But they can handle a lot of issues, frankly, over the phone. But then they can also come out and do that. So I think that is a huge one. I think having, we call it schooling to mental health, having mental health professionals in clinics, frankly, from clinics, being in the schools. They can build public and private insurance. We've seen that to be a wonderful model because again, it is early intervention. It's normalizing it. Kids in elementary school like, oh, there's Miss Jane, the therapist. And so it becomes more normal, which is also good. To do that. But I do think looking at the wellness piece for kids so that we're not getting to that point where, a mild anxiety because they didn't want to go to school that day all of a sudden becomes school refusal and high anxiety. We have to intervene earlier. And I think the biggest issue that we need to learn to intervene earlier on is psychosis. We do have first episode of psychosis programs in Minnesota, not enough, and they now all have waiting lists. And I think with the legalization of cannabis, we know that we're going to see higher rates of psychosis, and we need to be intervening. If we can, if you think, so I have a public health background, right? So we know there's kind of, there's different types of intervention, but tertiary is when you just want to make sure that illness doesn't become a disability. And so schizophrenia is one of the most disabling conditions in the world. If we can intervene early and not have those young people become, disabled for the rest of their life, that's a game changer, right? They'll be able to work, they'll be able to live in the community. It's what we have to do.
So could you define psychosis for me so everyone is
Sure.
really
So
clear on that?
psychosis is when you're hearing things that no one else hears, seeing things that no one else can see, delusional thoughts, hearing voices, those types of things.
Kimberly or Jessica, anything you would add about crisis teams or?
Yeah, I think she covered most of it, as far when you talked about the ER diversions, I think it takes a public-private approach to make those things happen. As part of Hennepin County, we have the hospital, and then we have kind of safety net primary care space that North Point is in. But we have to start working better together to ensure that we're identifying those users that use the ED frequently, so that we can do some of this diversion. So we're working on that now to really start to try to identify those individuals and families, because we pretty much know who they are because they show up all the time. But that diversion piece, I think when we think about mental health, in the example Sue provided, I think the counties and the cities have a space to help provide that alongside the state, because Hennepin County had that in kind of the county homeschool, and then they decided to get rid of it. Now you don't have any place for these kids to go now. And so who's responsible, right? Because parents are saying, help me, but I don't know where to go. And so I think there needs to be some conversations in that public-private space to take care of that. Because I think, as you said, when we can take care of the kids at that stage, then we'll save money on the back end.
One more question? Yeah.
Hi, I'm Bill Barberg from Insight Formation. And given decades of research showing how important early infant brain development is, early relational health, attachment and such, how important do you think it is that our efforts on mental health focus on that 0 to 3 or prenatal to 3? And if you agree it's important, what do you think are the biggest opportunities and best ways we should begin to take that more seriously and put more effort into that?
Early childhood. Jessica, anything? What are you seeing?
We just been training people on DCO5. To do that, we need to get in there before they're even pregnant. We need to be intervening a lot sooner, and that's why we have a lot of classes that are geared towards supporting people who are either considering becoming pregnant and or are currently pregnant, so that we can get in there then as early as possible. Usually we found that when we do community events, especially with our health, not just with women, but with the fathers too as well, because we haven't done a good job with the inclusivity of having our fathers in the family unit. When we've done that early on, we've had more opportunities for people to come up to somebody and say, hey, we're going through this right now. I really need some help. Or my wife, this is happening to my wife right now, and I don't know what to do. Like, she's got postpartum psychosis, or she's got postpartum depression. We typically don't talk about that, right? We're able to get in there and just say, and normalize it and say, let's talk about this. There are resources for you. So I think it really is important that you got to start before they even get to that point.
But he's bringing two things together, like the maternal health crisis and the mental health crisis in one thing. And so I think it's, your question is a good question. And how do you provide the service in a way that is culturally responsive to that individual? I mean, for Black women, no matter what their socioeconomic class, 0 to 3 is a difficult time for them if they're going to have a baby and then deliver the baby. And so we have specific culturally responsive services for those individuals, right? We make sure that their OB care, they get in their first trimester, they have all the supports that they need, and the system has to be set up in a way that is not cumbersome for people to access the care. I think that's the biggest thing for me, is access. If I show up, I don't want to have to fill out a whole lot of paper. I don't want to have to answer a whole bunch of questions. I know I'm pregnant, I'm going to need some help. So I'm going to need you to help me figure it out. So bringing those two things together, that's a very interesting question. And I think about it a lot because we have a lot of young people who show up and need the support. So it's going to take, just like his question, where's the public and private support in creating a different system that actually works for the people who actually need it.
I'm going to throw something out there that might be a little controversial, but our obsession with work doesn't always make sense. And so we have people on, MFIP, Minnesota Investment Plan, or welfare, across the country, and it's like, within a few months, these moms are supposed to go to work. They don't get that much money to pay for good child care. They are under stress because they're living, frankly, in almost abject poverty. We only raised the rate after 30 years, right? I mean, it was just absolutely ridiculous. And so why we think that stress and the poverty and all of that is going to still be okay for that little baby is beyond me. And so if we really do value and treasure children, then we shouldn't be forcing women who are poor to try to work at the same time. Let's help them really raise their children, give them the support that they need. And I think we would frankly see much better outcomes than what we're doing.
Thank you. I think I'm getting the cues for time is thank you for having us.
Well, Angela, Jessica, Sue, Kimberly, thank you so much. That was an amazing, excellent conversation. I really personally valued the different perspectives and stories that you all brought, and Angela, how well you kept it moving. So thank you so much for joining us today. We just have a little bit left to the program.
Thank you also to the panel. Sue's announced that she's retiring, and when I think of the hard work of public policy, it's not about developing slogans, it's about doing the actual work of informing legislators, the public, about changes. And I can think of very few people in my lifetime who've been more effective advocate for public policy than Sue Aberhold. And in addition to that, she's built a phenomenal organization that has provided support and resource to so many families and individuals who are struggling, that find a place where they can go and feel comforted and informed and have a trajectory that's based on hope. And I will tell you, over the years that I've been in the community, like I said, I was fortunate to meet Sue early in my career. I can't tell you the number of times people have approached me over the years and talked about how Sue personally connected them with resources that made a transformational, comforting, caring difference in their lives. So Sue, we know that over the next few months, there's going to be lots of accolades and recognition coming your place. I think you're probably need a new room on your house to store all the plaques. So we decided to do something different. And on behalf of CHC, on behalf of the families and the individuals you have touched, many of whom will never know what you did to help them, the legacy that you've left, and if I might be so bold, on behalf of our community, I want to thank you.
Thank you so much. Thank you so much. I just really appreciate it, and it's been an honor to be a part of this movement and a part of this organization. So thank you.
Well, I'm just going to say a few last words about what you all can do now to build capacity in organization and eliminate barriers to health. I'll be joined by my colleague, Becky Arrett. We'll just talk a few minutes about what you can do and how you can get involved. So if you're new to CHC, hopefully you've heard today that what we do is build capacity in organizations to eliminate the barriers of health. We're a national organization, and we've done that since the 1950s.
Alrighty, so up here, if you currently do not run a workplace giving campaign with CHC, we have many opportunities for you. So we partner with over 1,500 nonprofits and 500 employees to impact 20 million lives every year. So we have an all-in-one digital platform called Purpose Platform that offers payroll giving and real-time reports, customizable fundraising pages, volunteer coordination, so you can volunteer with some great nonprofits across the state, across this country. And we also, new coming out this year, is we have some cause funds that are focusing on real issues facing a lot of communities. Mental health, you see, is one of those. Disaster relief, veteran health. So we're really working hard with our causes to generate giving with the younger generation who really wants to give to cause-specific funds. So, and then really quickly, I mentioned volunteerism. We can build volunteer projects to fit your company logistics, whether it be hybrid, remote, in person. We can work with the nonprofits so it meets both their needs and the interest of your employees. And really, we engage employees through meaningful experiences. I believe in the whole see, feel, touch. So if you see the nonprofit, if you feel the work, that the impact that you're giving back to that nonprofit, and to touch it, you feel that connection back, and you can potentially become donors and feel more connected to the community at large. And the nonprofit partnership. So we help nonprofits maximize workplace solutions to boost funding and awareness. We met with some of our nonprofits early this afternoon to talk to them about access and increased visibility through workplace giving campaigns, marketing and communication support, connections with potential donors, even their current donors, and we offer compliance and financial reports. So really it's the holistic approach of what CHC could offer both to our companies, nonprofits, and any organization in our community. And I'll turn it back over to Morgan.
Thank you, Becky.
Yep.
In addition to that, we can help you develop and express your leadership. The Leadership Council for Healthier Communities is our executive and senior leadership networking forum, where senior leaders of corporations and national associations network with each other to find alignment and cross-sector collaboration on health problems facing our country. Leaders can align on any different sort of issues that affects their organization and community, from food insecurity to gun violence to affordable housing to, of course, behavioral or mental health. So this is our executive forum that has been started by pharmaceutical, financial services, and national advocacy organizations. CHC University is our educational offering. It is geared towards helping the nonprofit community across the United States thrive. It is a network of over 8,000 nonprofit leaders, and they get webinar content, thought leadership content, and curriculum and certifications to make sure that their organizations are successful and effective as possible, which is extremely important in our current economic environment where we're seeing a lot of contraction across the sector. But CHC is there to make sure the nonprofit and social sector is healthy and can serve its communities. Sponsorship opportunities are available if you want to see in your organization a healthy nonprofit sector, or you want to sell products and services to nonprofits. We're an excellent partner to help you do that. And lastly, you can increase your own effectiveness and impact. You can support one of CHC's impact initiatives. CHC also has impact initiatives that are geared towards eliminating health barriers in particular areas across the country. We have mature impact initiatives for maternal health, breast and cervical cancer, and vaccine education and awareness, and growing impact initiative in early childhood development. You can fund any of these. You can bring them to your community if this is a disparity that you have in your community that you are wrestling with and dealing with as a community leader. In addition to that, CHC can help you with a community needs assessment for any health issue that you're experiencing in your community. Very similar to behavioral health today, CHC can work with the community-based organizations in your community in order to find what those barriers are and then work to address them. Our approach is issue and geographically agnostic. We can help any community in America with any health issue. And then lastly, you can increase your own impact. You can have a training and education series for your own employees. If you're a large employer that has multiple hundreds of employees, we can work with your workforce to improve their health and wellness through trainings and co-branded materials. If you are a grant maker, if you are a corporate or private foundation, we can help to build the capacity of the community-based organizations you're already invested in through technical assistance. And then if you're new to the health equity and the health disparity landscape, you can partner with our organization as your program office to get your grant-making function off the ground and select and invest in high-performing nonprofit organizations that can close those social determinants of health in your community. Ways that you can get involved with CHC. So please collaborate with us, please contact us, and we'll be contacting you, all right? Thank you all for joining us. Minnesota Public Radio has told us that the conversation will air in late June or early July, probably a time when Angela's on vacation. And we'll make sure you all know when exactly that is so that you can listen again and you can tell your friends and colleagues about the show. Thank you so much for joining us today.